And for us in Nigeria, I will say good evening. That is the world for you. And the time variation within the different countries. All right, and thank you, Danielo. Thank you very, very much for inviting me. I think the pleasure is mine because I don't know whether it's a common thing with us virologists. We are so passionate, and my passion is tied to virology. So whenever I have opportunity to share, especially arbovirology, when I have opportunity to say one or two things, I'm always so excited. And I just pray that you will follow me gradually and patiently. And the topic I've shared with us is the vilification of malaria parasites for arboviruses in Nigeria. And there may be many perspectives, but today I will focus on the virological perspective. And before I start, I want us to just have a good, strong imagination thinking. Let us assume that people accuse us falsely, and it's false accusation, and you feel bad, very strongly about it, and you decided to take a legal suit to kind of vindicate yourself. I think that is, I want us to have that imaginative thought and imagine malaria so often accused, blindly accused. Malaria now decided to go to court for justice. So I think let's see what the court has to say about the case. How do we? So this is the situation. We have the presiding judge, who happens to be a general physician. And we have the plaintiff in favor of malaria. We also have the defendant in favor of the viruses. And we have the accusers, who are actually the patients. And then we have so many witnesses. Both the plaintiff and the defendants, they have witnesses. So let's see how it goes. Next slide. Ibrahim, this couldn't. Cannot move the slide. Okay, let's get the full.
Is it frozen?
Yeah, we are trying to move the slide.
Okay.
Ibrahim, what is it? It has not moved. All right. So before the plaintiff could actually narrate the story, he decided to give the court a background information. And according to him, every febrile illness in Nigeria is diagnosed and treated as malaria without a lab testing. And sometimes, if symptoms persist, it is assumed to be typhoid. In that case, the treatment automatically will include antibiotics to the anti-malaria treatment. Now, after a few days, if the symptoms elapses, then it's okay. But if they persist, the patient would visit the hospital then for medical attention. The plaintiff continues. Now, he narrated to the court that the suspicion index for malaria is very high. And the judge asked, why? And he gave the explanation. Nigeria has the highest malaria burden, about 27% cases, and then associated deaths. Then he cited in 2021, it was recorded 68 million cases and 194,000 deaths associated with malaria as estimates. And he continued that malaria accounts for roughly 55% of all malaria cases in the world. And he concluded that this is because malaria could be diagnosed easily in the 3-tier of healthcare facilities. When I mean 3-tier, it includes the federal, the state, and the primary. And what are the factors that facilitate this high suspicion index for malaria? It's because malaria is transmitted year-round. There is a high vegetation, humidity, poor sanitation, poor waste disposal, and all those factors and much more facilitate mosquito breeding. And to crown it all, there is what we call poor health-seeking behavior of the people in Nigeria. The plaintiff continues to give the background that why are they so related and why are they so confused? Because the clinical symptoms of malaria and the clinical symptoms of arbovirus infections at the early stage, they are typical in the sense that they are almost the same. If you check what is on the slide now, they are the same, except the rash. People hardly associate rash as malaria symptom. But when I went into, personally, when I went into the literature, I discovered that some strains of falciparum can cause rash. But it's not really that common. But it's so common to have arbovirus infection with rash, whether it's dengue, whether it's West Nile, and whether it's which other one? I think Rift Valley. Some do cause rash. But when it came to arboviruses, the suspicion index for arbovirus is very low. The question is why? One of them is that routine surveillance for viral infections in Nigeria is very poor. I can count personally now, it's not the plaintiff, I'm adding my own on top of it. I can count viral infections that are of, let me say, high suspicion index, or let me say surveillance activities. Such include yellow fever, because WHO is doing active surveillance for it. HIV, because there are so many external donors. But to say routinely, no, there is none. Then secondly, arbovirus infections are generally underestimated, under-recognized, and under-reported. And among the health workers, it's the physician that should go and diagnose and say, oh, let's investigate this. There is low awareness among health workers, especially the physicians. So even if the physicians are aware, there is poor lab diagnostic capacities. Therefore, arbovirus infections and malaria, they have atypical symptoms and they are always misdiagnosed together. Then the judge, back to our scenario, the judge asked a question, asked the plaintiff, do you have any witness? Because you know the court depends on evidence. No matter how emotional you may be, the court does not know that one. All they want is evidence. And the plaintiff responded, yes, my lord. Then he said, please permit me to call my witnesses. Then the plaintiff arrayed medical lab scientists in the court to give their empirical evidence. The first witness said, oh, I've been working with dengue and I've discovered more than 60 published articles. And they use ELISA, NS1, MNT, PRNT, RT-PCR to establish these facts. And he cited that between 1971 to 2025, prevalence of 2 to 46% of dengue had been reported. But he concluded that he has not yet known any outbreak due to dengue in Nigeria. The second witness talked about the same about yellow fever, over 50 published articles. See the method used, see the between 1864 to 2025, 2.1 to 50.9, almost 51% prevalence had been reported. Not only that, Nigeria has witnessed 23 outbreaks between 1864 to 2020, with over 33,000 confirmed cases and over 8,000 associated deaths due to yellow fever. Then another witness, the third one, talked about chikungunya, more than 5 published articles, and they used ELISA and PRNT, and reported that between 1964 to 2026, there had been 5.8 to 37.5 prevalence rate of chikungunya in Nigeria, but though no known outbreak. Zika, the same thing, but between 1954 to 2016, they recorded 13.8 to 14.5% prevalence rate, but no known outbreak. West Nile, greater than 12 published articles. And between 1959 to 2020, they recorded 0.6 to 40% prevalence rate, no known outbreak. The same with Rift Valley fever with witness 6, more than 5 published articles. Between 1990 to 2025, they recorded 12.5 to 20% prevalence rate, but yet no reported outbreak. The judge now asked the defendant, who is defending the arboviruses, anything to say in defense? And he responded, yes, my lord. And he said, to some extent, he said his learned colleague is correct. In the sense that, number one, patients are not aware of the existence of viruses. So is that their fault? Is it the virus' fault that they are not recognized? He said, no, my lord. Then the second reason, he said, if viruses committed crimes and malaria is blamed, or let me say, if viruses commit crimes and malaria is blamed, is that the virus' fault? He said, no, my lord. Also, malaria has numerous treatments in the market. One, my clients, according to the defendant, that's the viruses, have none. My lord, is that their fault? He said, no, viruses did not make this feasible. Then, number 4, malaria has so many types of diagnostics, while those of viruses are scarce and very expensive in Nigeria. So this scenario often allows them, that's the viruses, to operate uninterrupted. Then he said, however, my learned friend is not 100% correct that malaria is falsely accused. Why? Because sometimes malaria exists on its own. Even though when they exist on its own, viruses will still, malaria will be existing on its own, but viruses will still be accused. Sometimes they coexist, but the availability of drugs will knock out malaria, leaving the viruses to perpetrate. Then the judge asked the defendant, any witness? And he responded, yes, my lord. I have so many witnesses, but 3 are only available in the courts today. He said, please call them, says the judge. And 3 medical lab scientists were presented in the courts. This is their evidence. Witness 1 said, articles were published on dengue 2013. both ELISA, NS1, MNTPR, and NT-RT-PCR were used to detect these viruses. And 1% of 310 patients with febrile illness had malaria alone. So in that case, accusing malaria that they were malaria, so it was correct. And some of them, some percentage were co-infection with arboviruses, but no known outbreak. Another group, Kolawole et al., in 2017, also did not detect even malaria at all, but detected 2.84% of co-infection of malaria and dengue. Then another group, Ogwezi et al. In 2025, used both ELISA and MNT to confirm that 62% were malaria, while 1.1% were co-infection between malaria and yellow fever. And we have been told there had been 23 outbreaks of yellow fever between 1864 and 2020, with over 33,000 confirmed cases and over 8 associated deaths due to yellow fever. Then the judgment now, the court said with the available empirical evidence presented to the courts, the judge gave his judgment. Number one, malaria has been falsely accused of offenses it did not commit. I'm sorry, there's an error there. Offenses it did not commit. Number two, it is not also the fault of viruses that malaria was accused of offenses they did not commit. And according to the judge, it's not actually the fault of the patients also, but the government of Nigeria. Why the judge blamed the government is that one, while the judgment of the judgment of the judge were based on the following reasons, and also there were also, let me say, recommendations on behavioral attitude. There is delayed health-seeking behavior of the people, and the people will not even do lab tests before any treatment or conclusion. Therefore, according to the judgment, there should be a lab test for an authentic diagnosis. Then on the issue of prescription, many Nigerians will just go to patent medicine store or pharmaceutical stores and buy drugs because they believe they had malaria without any lab tests. So the judge recommended that the lab results should be sent to physician for an authentic prescription. Then on diagnostics availability, the judge recommended that efforts should be geared towards making diagnostics available, affordable, and accessible in the country. And the judge also advised Nigerian government to endeavor to produce these diagnostics for differential diagnosis of febrile cases in Nigeria, so that at least that will bring make the availability, affordability, and accessibility more feasible in the country. And also, like some doctors used to say, what's the need of diagnosing a disease when you cannot treat? They just recommended that the country should embark, as a matter of urgency, more antiviral drugs. And the fact that because of low suspicion index for arboviruses, the judge recommended that efforts should be intensified to raise the suspicion index of arbovirus infections in the country, especially among the physicians and other health workers. Then the court adjourned. So now the court case is over. It's now left for all of us. Do we agree? If we were in the courts when this case was handled, do we blame malaria? Or do we blame viruses? Or do we blame the patients? Please, my case is over. Thank you very much.
That's great. So I love the way that you did the storytelling for this. So let me allow the microphones and videos for people to ask questions for you. So I was amazed that you people. So we have the microphones on and also the cameras. So if you have any questions, so please feel free to ask Professor Marycelin. I was very amazed. So you in Nigeria, it's not very common to do any tests for arboviruses, right?
No, it's not common.
Okay. So it's everything related to malaria right now. So
yeah.
So but malaria takes all the blame for those infections. Is that very expensive to do those tests in Nigeria? I have no idea. So what do you have available for this, for doing arboviruses infection?
Like I mentioned it in my talk, in Nigeria, there is no kit. And like I mentioned it, I asked you the question. I said, how do I get ELISA kits? I remember when we bought ELISA IgM and IgG for dengue, we spent over a million naira. All right, if you calculate that, how many average Nigerian can afford it? Most of those published work, you see, they got grants, they got support externally, and then they bought the kits. Those kits are expensive. When for the current PhD student I have, and I'm trying to buy dengue IgM, no, not dengue, Zika, they told me it will cost me 5,000 US dollars. How would I afford? The student could not continue with the work. We had to suspend it. So that is the question. At a time, because of my passion, I've been looking for a way or to send people to learn how do we develop these kits using local strains. And then if we learn how to develop these kits using local strain, then maybe we will come back to Nigeria and see how we can meander and then use local materials. Also, what we need to make the kits available, affordable, and accessible. If that happens, then routine testing for these viruses, I believe, will be feasible in Nigeria.
Okay. Yeah, because in the beginning, we were working with some in-house ELISA kits also. We infected the mice, we got the antibodies, and we do all the work using antibodies from mice and also the virus. So we coated the plate with the viruses. So this is something that we can discuss later and do some partnership with this, so we can work together to improve this. And I think that this is very important for us because everything here in Brazil, it's also expensive. We do a more active surveillance here in Brazil, but yeah, so Professor Eurico mentioned that no dengue ELISA serology for IgM. That's a question. It should be easy to use fixed infected cell cultures as antigen, right?
Yeah, even if we can produce, let me come to the first one you mentioned. Yes, if we can be trained, or the capacity of the country is built to produce in-house ELISA, you will not only do Marycelin a favor, you will do Nigeria a big favor. We need it. We need something to start with, but for now, there is nothing like that. Nothing, absolutely nothing. And then the second question on ELISA, did I get it well? ELISA, IgM, and IgG?
Yes, ELISA, using infected cell cultures as antigens.
Yeah, we like in my lab, we can use produce infected cells. But if you do that, what are you trying to achieve? If do you want to use it to produce ELISA antigen? Because we can produce infected cell and even inactivate it, either using chemical or heat. We can heat in. But if you want to use it for ELISA, what of the conjugate? How do we get the conjugate? How do we get the hyperimmune serum or mouse acetic acid? Or what are you going to do? Because, and then, I mentioned the delayed health-seeking behavior. And the, what do you call it? The curve for, what do you call it? Immune response to many of these virus infections. You see the lag phase, you see the log phase, you see the stationary, and then the declined. So now it depends on the phase between the onset of the symptoms and sample collection. Before, if you use PCR, it will work. I don't know whether you get the point. That timing for arboviruses is very, very important. But when the people don't seek medical attention at the phase, the log phase, when you can get the PCR positive, then it will not yield any fruits. I don't know whether you understand what I'm trying to say. It will not yield any fruit. So the diagnostic test you want to use depends on the phase at which the sample was collected. If it's more than 5 to 7 days after onset, you won't get PCR. And you may get PCR negative and call it false negative, whereas it's not. Though personally, normally for my country, I normally advise any assay, any diagnostic method for arboviruses should combine both PCR and serology, especially when the time of onset of symptoms and sample collection are not determined. That's the only way to really bring out the status of the infection.
Okay, and you don't do PCRs either, right?
We do PCR. In my lab here, we do PCR. But because of the delay, let me give example of, I had example with the Zika. We tested some serial febrile cases for fever, for Zika, and they were negative. Then when I checked the literature, CDC said, when it is negative, then you have to do IgM or IgG. And if it's IgM or IgG positive, proceed to MNT or PRNT. And if it's MNT or PRNT positive, then you have to also do the check for other endemic viruses because of cross-reactivity. So I have to retest it for dengue, and then if there was more than a 4-fold increase between dengue, Zika, and other, then I will now know which one is actually. So it's a long process. It's a long process.
Okay, if I understood correctly, so you need a very specific test for serology test.
Yes.
To distinguish between Zika, dengue, and other
yes,
viruses.
Because for flaviviruses, it's really difficult. For flavivirus, it's difficult because of the high degree of cross-reactivity among the members of the family. So anyone that is, if the worst, people using IgM, IgG to estimate dengue, whereas not to me, I don't normally consider it as anything because even PRNT, but you have to use 90% endpoints 90 to 100% endpoint. That's one. And also compare it with other endemic viruses and determine a fourfold increase between one virus and the other, or the three others at least, before you can say this is actually the infecting virus.
Okay. Any other question for Professor Marycelin Baba?
Danilo.
Right.
Yes, I would like to ask a question. Can I?
Sure.
Is there any Oropouche virus detected in Africa?
Is there any?
Oropouche.
Which one is that?
Oropouche, the Bunia virus from Brazil, South America, and that's being spreading to other countries.
I will not say there is none, unless I have kids to look for it and we don't find before I can conclude.
Okay.
Yes.
Fair enough. Fair enough. Okay.
So you also mentioned that you don't have any chikungunya outbreaks in Nigeria, specifically in Nigeria, right?
Even if you say there is outbreak, they will say it's outbreak of malaria. Bear this in mind.
Okay. So, yeah. Any other question?
I've had cases like that. Oh, there's outbreak of malaria. Malaria is killing people in so and so place. Personally, I will know it's viral, and by then I did not have the capacity, so there's nothing. I just kept quiet. But now we have the capacity. If we had a case recently, there was outbreak of fever and people were dying. We said they should send the samples to us. But incidentally, when we tested for yellow fever, we tested for dengue, we tested for West Nile, they were negative. So we now rested the case there. We did PCR on all of them. Yeah. Okay, so now the lab, we have the capacity for rapid outbreak response. Because in fact, I ordered so many primers for yellow fever, dengue, West Nile, chikungunya, Zika. So in case there is any outbreak, at least we'll be able to confirm it on time.
But you also perform some neutralization assays, right? MNT yes. And also PRNTs.
Yes.
For those viruses, and are they working okay? Do you have a lot of cross-reactivity between them?
Like I mentioned, you know, for WHO, the confirmatory test for yellow fever serology is plaque reduction neutralization test. So what I did in one of my papers, I compared MNT and plaque assay, and I discovered that they were comparable. There was no significant difference between the MNT, and you know how cumbersome plaque assay is. I can perform both in my lab here. Can perform. In fact, up till now, if any day you visit me, I will show you plaques of yellow fever, West Nile, dengue, the plaque, the shapes of different plaques, and I use BHK for them. They come out very beautiful. Then, I'm sorry if you are familiar with BHK. You know how beautiful BHK is. And when there are plaques there from caused by different viruses, they are very good to look at. So my MNT is working, my plaque assay is working in Nigeria perfectly.
Okay. So we have a question here from, I think it's Usman. Can a person be co-infected with both malaria and any arbovirus? Thank you.
Yeah, in my talk, maybe you didn't hear the court case when the defendant confirmed that not all the accusations are 100% correct, because malaria does exist. And sometimes they coexist with arboviruses. Even my personal work has confirmed it, co-infection between malaria and arboviruses. But the good thing is that when such a patient takes anti-malaria, malaria will go while viruses will persist. And you know what the people will say? It's resistant. Without any lab test, it's resistant. Then they can change 3 anti-malaria drugs in attempts to get rid of the virus. And you know what the viruses are? Many of them are self-limited. When they finish their course, they will go on their own. But people would think the change of drugs is that is causing or it's clearing the virus out of the system.
So were those cases, co-infection cases, confirmed by PCR or serology?
All right. The few I detected, I did both. There was one that I thought it was, I can't remember what it, but when I did PCR, it happened to be West Nile. It was not dengue. It was not dengue, and they co-infected with malaria. So it's like me, in my opinion, if it's not PRNT or RT-PCR, I will not even consider the co-infection of arboviruses and malaria reality. I won't.
Okay. So it's difficult to, I was just thinking here, so it's difficult to have an idea the percentage of population that is or was infected by one of those viruses, right? Because we don't have a serology test for that.
I mean, the percentage of the people infected. I think it depends. Like the one I cited, my own paper. I worked with 310 patients, and out of that, what was the? Let me see. Out of that, how many were infected? No, let me see. Yeah, 2013. Out of that, 1% had malaria alone. I can't remember the percentage that were co-infected.
Okay.
Yeah.
Not only co-infected, but also arboviruses alone. So it's difficult to have arboviruses alone, right? So
yeah,
everyone has malaria.
Yeah, some of them, there were also co-infection between arboviruses. You see dengue and West Nile, or you see yellow fever and West Nile. But it was difficult to see dengue and yellow fever. I don't know whether you get the point.
Okay.
It was difficult, yeah. But dengue, West Nile, dengue, chikungunya, there were many cases like that existed. And not only my own studies, so many other studies. I think I cited some of them in my talk, where they discovered co-infection. A certain percentage having co-infection between malaria and dengue.
Okay. Any other question? So I was just wondering, so probably, so if you don't have like a very specific kit for that, so can you distinguish between serotypes for dengue within your PCR that you're doing in Nigeria? So I don't know if you can distinguish that, or it's just like general dengue virus.
In my paper, I think the most recent paper on dengue, I used plaque assay to differentiate the four serotypes of dengue. In fact, something interesting actually was discovered, because there was a PhD student that used PCR to identify different serotypes of dengue from insects, from mosquitoes. He did not work on human samples at all, and he did it in southwestern part of the country. But me, I reside and I do most of my work here in northeastern Nigeria, and I use plaque assay and also detected the same serotypes and the same serotype co-infections. You see type 1, type 2, type 3, or type 1, type 4 in a patient, and the same pattern using the PRNT. And now if we use Lanciote primers, I discovered recently, I have a PhD student right now. We tested over 1,000 febrile patients, and we used three different real-time PCR-based kits, namely Real Star. I know you're familiar with Real Star. We also use Novalplex, and we use Barbefectus. These are 3 detecting multiplexing. No testing, detecting more than 3 or 2 serotypes or 2 arboviruses at the same time. And they were all negative for dengue. These 1,000 samples were negative for dengue. Then I decided, I remember that during my PhD, I used Lanciotti et al. 1992 primers for semi-nested PCR. And we were able to pick positives. Personally, I did not understand. Because with Lanciotti, you pick dengue before, then you now use type-specific primers to detect the serotypes. And we were able to get results.
Okay. Yeah, so we used the Lanciotti also in the past here. So that's another one that we are using right now. I think we use a version of Lanciotti for qPCR, RT qPCR. But yeah, there's another question here. So considering the wide diversity of the viruses circulating in regions like Nigeria, how reliable is clinical evaluation as a first-line approach? And are there specific clinical or epidemiological patterns that could help suggest infections by less commonly diagnosed viruses, such as Oropouche virus or other emerging arboviruses? I think you mentioned that Oropouche, you are not aware of that in Nigeria, right?
No, we are not. But I wouldn't mind if we have a positive control and the virus itself. We have so many sera, and I have so many MSc and PhD students that can work on it. We wouldn't mind at all to really confirm whether we have it or not. And before I double into this question, permit me to tell you something very interesting. We did Aedes aegypti. We did a genotyping of Aedes aegypti. And we were able to get species of Aedes aegypti that was from the phylogenetic analysis that was traced to Brazil. So you can answer that question too. So it's better, it would be good for us to try this virus to either affirm or refute whether it's there in Nigeria or not. Then they'll come back to the question. I will say that using clinical evaluation for arboviruses infection, it will not yield any fruit at all, like I said, except, remember that arboviruses have 2 phases of fever, of symptoms. The first one that is non-specific, we call it malaria-like and can easily be. Then the second phase, when after remission of 1 or 2 days of symptoms, it comes back with fever abruptly, and then it can be accompanied with hemorrhagic or encephalitis or any other one, depending on the infecting virus, that So if it reaches the hemorrhagic signs, yes, it can only say it's viral hemorrhagic fever, and yet many of them also can be implicated. So it's really difficult to use clinical evaluation to suspect whether it is this arbovirus or that arbovirus. It's always good either way to be confirmed in the laboratory.
Okay, that's great. Any other question? So again, we thank you very much for the talk. Now, there's Gabriela said that very important talk. Thank you, Professor Marycelin and Beautiful for this. And I would like to thank you so much for your talk. And I think that this is important for us because it's important for us to share knowledge between countries. So, and I think you can count on us for this. So well, let's discuss a little bit if we can do something together to help the issue of misdiagnostic in Nigeria. So maybe we can discuss any recombinant protein that we can use for ELISAs, or something that we can put together so we can start a kind of project together just to help and put together efforts for that. So I think that would be very important.
That will be really fantastic. And remember, we need that oral push virus. We need to find out whether it's there or not. If we could get the vector from Brazil, which I think could be linked to second-hand pulses cars we bought from Brazil. Who knows? It's a possibility, but it's good to rule it out. Sure. I cannot tell you that nothing is there unless I test it. We are scientists. We have to test it and confirm. And please, like I've mentioned to this group, that if we are able to produce ELISA against any of the, especially dengue, the most common is dengue. Dengue is there in Nigeria. It's endemic, not just there, endemic. And it hides under malaria, according to my presentation. If we can even start from there to produce ELISA kits, in-house ELISA kits, please, you will not only do me, you will do me a favor by, how do I put it? Say, my vision in life, in actualizing my vision in life. But you will do a lot for Nigeria as a country, because there's nothing we can hold on to right now. Please, thank you very much.
Let's discuss that. Maybe we can host some of your students in here. So
that's it. But that's another good good possibility, collaboration, where the student come and spend maybe 3 months, or 6 months, and acquire the skill, and then come back and then transfer the technology. That would be fine. That would be fine.
Perfect. Yeah, I know a person in Africa that we can start doing this, and get together to have your students here in Brazil. We used to have a program for that. It was between US, Brazil, and Africa, but let's discuss that. I think it's going to be very important, and it's also a pleasure to have one of your students here in Brazil with us to learn a little bit more, and also to do this work together.
That would be fantastic. Thank you very much. I really appreciate. Thank you for your concern for us and as a country, and for me as a virologist. I appreciate you. Thank you. Thank you very much.
Thank you for your time. Thank you for your talk. And thank everyone for attending this. Thank you.
Thank you.
Until next week. Bye-bye.
Bye.